Morning, everyone, and thank you for inviting me. I'll start out with a very short declaration, because we all live in a wealthy part of our planet, and my experiences and my examples will reflect these facts. I'm sure there are different situations in other places. Last year, our health directorate came up with this Norwegian national guidelines about gestational diabetes, telling us it was from September 17, telling us that the threshold from whom to be tested for gestational diabetes will be reduced from body mass index 27 to 25. That means 7 out of 10 pregnant women will have to do the oral glucose tolerance test. And as far as I know, in UK, the threshold is still 30. And it says that every woman giving first birth above 25 years is expected to be tested. That means in Norway, almost everyone, because there are about 25 giving first birth. This has led to lots of discussion. In newspapers, pregnancy care on the wrong track, 70% of the pregnant women defined as abnormal. And in our journal of the Norwegian Medical Association from April this year, a gynecologist, Professor Bjørn Bakke, is telling us that this is like shooting sparrows with cannons, really overkill, because the number of newborns with birth weight about 4.5 kilos, which is the aim of the guidelines to reduce, will at most be reduced from 2.7% to 2.5%. So this has led to a situation where the chair of the Norwegian College of General Practitioners, Petter Berlin, this spring says that we might give our GPs the advice not to follow these guidelines regarding gestational diabetes. And how on earth could the college end up with this? It started 25 years ago, the establishment of the Norwegian College of General Practice and some of them. And already in the early 90s, this then young Norwegian general practitioner, Jostein Holmen from Trondheim, he did his thesis and PhD work. And during this work, he defined what he called the medical industrial complex, meaning a very close relationship between the doctors and the pharmaceutical industry and the industry of medical technology. And we might see that this complex, this real close relationship, has been a major contribution to the medical shift we see in the last decades, from treatment of sickness that's already here until prevention of future illness and diseases. So our college has worked with this for almost 20 years. 7 theses in 2001, a book called Diagnose Risk with Elisabeth Svensson. Are you here? Oh yes, up there. She's here. And the college has done some policy documents of preventive health care. We've written papers in our journal, and we have made a position paper that has been lifted up to the Nordic level, and the Nordic Federation endorsed it, and it's published within the WONCA system globally. So that's very interesting. WONCA is the World Organization of the National College of General Practice. And as late as June this year, the WONCA Europe Council endorsed and has developed, under the leadership of Professor Johannes Sigurdsson here, oh yes, a position paper on overdiagnosis and actions to be taken. And it's based upon our Nordic paper, but it's revised and it's much better. So congratulations, Johan. I myself started as a young GP 39 years ago in this beautiful village of the western side of Norway. And I immediately loved the nature, people, patients, and my work. And I still love my work from this office, although this beautiful apple tree is still not there. It's replaced by a complex of flats, of course. But during these years, the work as a GP has changed pretty much, I think. And it all started, as John says in his gospel, in the beginning was the Word. And it was a dialogue between the doctor and patient. What's your problem? What's your problem? But during the last decades, there's been lots of new tasks to be done. Conditions and risk factors of health that health authorities claim that the GP is responsible to check and monitorize. And there's almost nothing left that we shouldn't. So you might really ask, where do we find the person? It's difficult. All this has led up to defining these different types of overdiagnosis as we can see it. And I'll show you some of them. First, what we call avoidable overdiagnosis, that when existing knowledge and guidelines that aim to limit overconsumption and overdiagnosis are ignored, or I call it bad medicine, perhaps. The case one is one of my patients, Jeanette. She's 34. She's divorced, 2 children, 8 and 12. She's a counter at the supermarket. And she came to me because she felt tired, loss of energy, headache, and she was concerned about malignancy. It must be something really serious, doctor. But my clinical examination was normal, didn't find anything special, but the further history said, she told me that she got no help with the 2 children, and a boy at 12 has got ADHD, and in fact she's not slept well for several months. But the tests and investigations are required in a situation like this. How do we deal with blood tests? How conscious are we when ordering blood tests? Are we led by habits or led by clinical indication? Do we order lots of blood tests just in case? What about the increasing patient rights and demands? How do we deal with increasing demands from the patient? We must do more. We must find anything that might be wrong. What about further investigations, x-rays, scans and all that? She says, please investigate everything, doctor. I want to be absolutely sure there's nothing serious. And when using those kind of technology, we know we find lots of what we might call internal wrinkles. There are lots of abnormalities found in scans of healthy people. Disc bulging, labral injury, Morton's neuron. That's just a few examples. Lots of them. We know that. And in my clinical work, I very often use this drawing, this figure, because it's telling me, and I say to my patient, if I do next to nothing, I'm sure that it might be high risk for making error. But it's not so that when you're doing more and more, that the chance of total error will be reduced. No, it's increasing again. Why so? Yes, because we're moving into an area where lots of normal variation. And there's a breaking point there. And I said to my patient, that's the point where I'm allowed to use my professional judgment, and we make a shared decision. This is enough. This is okay. Leave it here. Then more unavoidable, difficult types of overdiagnosis. I think good medical practice is associated with unintended harm, and that including lots of defensive guidelines. We're drowning in the guidelines. Really. Every guideline says earlier, find it earlier, do more, everything. All the time. And of course, there is something appealingly and intuitively with the early diagnosis. The earlier the better. But we'll have to realize that it's not possible to find all potential serious conditions without at the same time make extensive overdiagnosis, over-investigation, and over-treatment. This popularity paradox is very challenging with educating people, because they feel healthy, they come to the doctor, they call up to the doctor to do some investigation, they find something, they remove it, and they feel cured. And this is a vicious circle with such survivor stories giving more useful screening is to be, and more intensive screening and more overdiagnosis. And it's a vicious circle. So it's a problem talking with the patients about this. It really is. And other example on when good medical practice is associated with unintended harm is a paper from Gisle last year in the New England Journal of Medicine, where he shows the incidence and mortality trends for breast cancer, prostate cancer, thyroid cancer, melanoma, showing that the incidence of these illnesses are far higher in the high-income countries, in the wealthy countries, than in the low-income countries. But the mortality is just the same. So this is a very nice curve showing that we're doing too much in the wealthy side. I can't resist the temptation to show you the very last Norwegian national guidelines about the total pregnancy care. It's from June this year. And the director says, the pregnant woman should contact the doctor or midwife as soon as possible after a positive test. We recommend that the pregnant should be offered a consultation within 1 week. So I ask, why don't the health authorities ask Dr. Midwife to give advice during the conception as well? I mean, the sooner the better. Disease mongering. Normal life distress and obstacles are included on the domain of the medical problems and disease, and I think that no one has ever said it better than Iona. It's some years ago. But she says, disease mongering exploits the deepest atavistic fears of suffering and death. It's in the interests of pharmaceutical companies to extend the range of the abnormal so that the market for treatments is proportional enlarged. I think that's a very good quote. And during my almost 40 years as a GP, the rules are changed. What is hypertension is changed, hypercholesterolemia is changed, diabetes is changed, heart infarction, heart failure, renal failure, asthma, polycystic ovarian syndrome, osteoporosis, several psychiatric diagnoses, dementia, bipolar disorders, ADHD. Always the threshold for including these diagnoses is lower. Always. And we as a GP are experiencing the sum of it. But this is not the whole picture, because we have all these pre-diseases and even early stage, early stage pre-diabetes. That's a new one. Pre-hypertension, pre-heart failure, pre-dementia, pre-cancer condition. And I think that the life is reduced to a pre-mortality condition in this perspective. At the same time, the death is a treatment failure. So this is the situation. And we know that the utopia, the zero vision, or the risk medicine, it's like this, that recommended thresholds values for risk intervention do not express medical facts, but stem from consensus founded on research-based data and subjective value choices. The consensus process is often influenced by professional circles with strong and committed opinion leaders, and the pharmaceutical industry and certain specialists focus heavily on biological measurements and the use of medication. Of course, the problem is that the line of benefit and the line of harm are not parallel. Of course, when we are got really high risk for future illness, the chance of intervention is to have a net benefit. The higher the risk, the higher the chance. But on the other side, when the risk for future illness is not that high, the chance of net harm is increasing. Mental illness have lots of increase in number of diagnoses and number of pages and the chance of falling into it. The case 2, Kevin, 22, came to me with he should have a driver license, and he had put on that he has a diagnosis at 14, ADHD, and I asked him, why? Yes, because my mother and teacher, they say I couldn't concentrate on mathematics, there must be something wrong. But how's life now, I said. He was 22. No, I'm married, wonderful wife, 2 lovely children, I'm a carpenter, I got a house and a nice job. Don't you have anything problems with your concentrating? No, no problems. Does he still have ADHD? Has he ever had ADHD? What in fact is ADHD? We know that diagnoses are medical constructions, no natural phenomena based upon laws of nature. It's medical maps. And there are written lots of things about this. You, Alan, has written your book, Ray has written several books, and so other. This is the last Norwegian book, came this spring from a Norwegian psychiatrist from Odda. It's called A Less Medical Psychiatry. How should we understand mental disorders? Should we understand them within a medical model or in a contextual model? And for my patient, does he have a disease? Or does he have a normal and expected reaction upon difficulties in his life? Trumodder says it like this: the present medical framework of understanding is a major cause of increasing number of phenomena described in medical and psychiatric terminology. Then we have the conflict of interest-driven overdiagnosis, where you have selective and skewed presentation of scientific data and evidence. And we can't trust the guidelines. This is from 2013. And she said that despite repeated calls to prohibit and limit conflict of interest among authors and sponsors of clinical guidelines, the problem persists. And in this paper, 71% of the chairs of clinical policy committees and 90.5% of co-chairs had financial conflicts, and 12 such conflicts can have strong impact. And furthermore, the pharmaceutical industry has cheated us. Richard Horton said a couple of years ago that much of the scientific literature, perhaps half, may simply be untrue. And as a clinician, I'm eager to ask, which half is true? The commercial medicine are a bad guy, really bad guy. This is an advertisement in Norwegian paper Aftenposten some months ago. It says, I'm healthy, as far as I know. And if you read it further, you really got the impression that you should never trust the feeling of health. And what they do is they sell a false sense of security. And it's easy sold. We know that general health checks among the healthy, there's no point. Fear-driven overdiagnosis. It's an epidemic of our time, and Western culture highly risk-averse. Every clinician wants to do a good job, feels insecure, and we fear sanctions from the patients, from the authorities, from the media. And it's an ever-increasing demand on perfectionism, and it's driving us against the defensive medicine. Typical situations: pains, loss of energy, it must be cancer when stopped. Further investigations. A patient back from hospital, we didn't find any cancer, but the GP should consider further investigation because of the following findings. And what about polypharmacy of the old? In sum, this development, I think, is putting normality and diversity under pressure. The resources are transferred from ill to an increasing number of worried well, and we are making a lot of harm. So, we know that the burden of life and the lottery of life always will give us patience. And I think that we all should remember and recognize Erik Gisle, where he says that the person is an embodied, purposeful, thinking, feeling, emotional, reflective, relational, human individual, always in action, responsive to meanings, and whose life in all spheres point both outwards and inwards. And virtually all of a person's actions, volitional, habitual, instinctual, or automatic, are based on meanings. And since we are in Denmark, I have to quote 150 years old quote from Søren Kierkegaard, where he says, if one is truly to succeed in leading a person to a specific place, one must first and foremost take care to find him where he is and begin there. This is the secret in the entire art of helping. That means we should open our eyes, ears and nose and close our mouth. Oops, I said open your ears, guys. And we have to discuss with the patients the uncertainty and tolerating uncertainty. This beautiful paper from 2016 defines medicine is a science of uncertainty and an art of probability. And I think the art of making decisions in the face of uncertainty is one of the huge challenges we have. And even talking with the patients about the uncertainty of life, how to live with the uncertainty of life. We have to be better in the art of saying no. I'll finish up with a quote from the late Per Fugelli, a Norwegian professor, died last year. He's made this chronicle paper in the Dagbladet, national paper in Norway, 10 years ago, September 2008. And he says, the health decision has made the perfect human being as its goal. It cultivates the health as a new God. The body is a new temple. The body must be built, clean, and kept holy. Every day the lifestyle must be ennobled. The immune system must be strengthened. More and more of discomfort of life gets a diagnosis on it and appeal against it. More and more of the risk of life is possessed by protection. I think that's wonderful said. So we really got to fight against dreams, don't we? It's very nice we have this conference and congratulate. We'll have just say one word about this following workshop in the meeting where we go further into the art of conflict. So, thank you.